Welcome to AETCM, the Emergency Medicine channel. Today we are presenting a case of 56-year-old male who presented to ER with complaints of painful prolonged erection following papaverine injection. So coming to initial 10-second assessment, airway was patent, no pulling of secretions, breathing, respiratory rate was 16 per minute, saturation was 100% on room air. Air entry was bilaterally equal. Coming to circulation, BP was 140/90 millimeters of mercury and heart rate was 100 per minute. All peripheral pulsations were equally felt. Coming to disability, GCS was full and patient was having a pain score of 8 to 9/10. So we had started, since the pain score was too high, we had started directly on injection fentanyl. We had initially given 20 microgram stat and for plan to titrate. And then exposure, patient was afebrile.
Was the patient's pain subsided with fentanyl?
Patient initially pain score was reduced, but during the procedure also he was having pain, so we had again given 20 microgram. And coming to secondary survey, ample history, there were no allergies, drug or food allergies. Coming to medical history, there are no regular medicines, and coming to past history, patient was having a known case of CA prostate, acinar adenocarcinoma. He was on injection leuprolide and androgen deprivation therapy. And since patient was having decreased libido, he was treated for he was planned for Doppler, penile Doppler. And past history, there are no similar history in the past. Last meal was 4 hours before. And coming to events, patient is a non-case of 59-year-old male, non-case of CA prostate, acinar adenocarcinoma, on leprolide and androgen deprivation therapy. He was having some decreased libido and erectile dysfunction, so he was planned for penile Doppler. For that, he was given injection papaverine, cavernosal injection, and following that, he was having a prolonged, persistent, painful erection, presented to ER with Priapism.
So, what is Priapism?
Priapism is a painful, persistent erection without a sexual stimuli. And if it is more than 4 hours, it is prolonged. If it is less than 4 hours, it is prolonged. And more than 4 hours, it is...
it is called Priapism and it is more than 4 hours. So, if it is less than 4 hours, we call it as prolonged erection. So, is there any difference between this 4 hours? If it is less than 4 hours or if it is more than 4 hours, is there any difference? Terminologies are different.
Importance can happen if it is...
It's just terminology. Even if a patient presents to us less than 4 hours also, the management will be the same. It is just that the terminologies are different. Okay.
So we had called for urology consultation and they had came.
So the patient was still having pain after giving fentanyl also. Okay.
So they were planning for intracavernosal aspiration. So initially they had given a lot.
So what are the examination findings?
Coming to examination, patient was having like erection was there and there was mildly edematous penis.
And very tender.
Very tender.
So what are the different types of Priapism?
Priapism can be ischemic and non-ischemic. Non-ischemic is less common.
Yes.
Ischemic is less common.
No, non-ischemic is less common.
Less painful, and the management is non-urgent embolization.
So ischemic Priapism is a urologic emergency. So what is the basic difference between an ischemic and a non-ischemic Priapism? Pathophysiology, why is ischemic Priapism an emergency and non-ischemic Priapism not an emergency?
Ischemic Priapism, it is venous occlusion.
In both, there is corpora cavernosa are the erectile tissues. So these erectile tissue contain blood vessels. So when these blood vessels dilate, that is what they gave papaverine injection for doing a Doppler to check for his erectile dysfunction. So when you give an injection and it dilates the artery, so there is arterial dilation which causes the erection. injection. So what happens in ischemic priapism, because of the high pressure, the veins get occluded. So that is like a compartment. So the patient will have very severe pain, penis will be very tender, or when you palpate, the pain will increase. But in case of non-ischemic priapism, the pressure is not so high so that the veins are flowing. So that is why you call ischemic priapism a low flow priapism, and that is veno-occlusive priapism, and non-ischemic is a high flow because the veins are still patent. So that is why the tenderness, the presentation of the patient will be not very severe than an ischemic priapism. So in this patient, he had come with erectile erection of the penis, no, and it lasted also for more than 4 hours. So this is priapism. So in such patients, what are the things in history that you should ask? So what like you should ask some history to say that why this occurred. So what are the things that are relevant in history?
Here there was cavernosal injections.
So this is also ischemic priapism. So what are the things that can precipitate an ischemic priapism? Like injections are there. Then there are, other than papaverine, there are prostaglandin E1, alprostadil. So these are the intracavernosal medications that can produce. Then there are drugs like alpha antagonist, prazosin, these and all can cause, and certain antipsychotics, SSRIs can induce. And there are also certain hematological conditions, which are the hematological sickle cell disease, thalassemia, those which are hypercoagulable disorders like thrombophilias and all, and hyperviscosity syndromes like polycythemia, these and all can present with that. There are priapism, ischemic priapism seen in certain infections. What are those infections? Certain infections, certain neoplasm like prostate cancer, bladder cancer, they can have. But there are certain infections which can predispose to ischemic priapism, like malaria, rabies, the scorpion bite and all can induce ischemic priapism. So that is ischemic priapism. So if the patient is having non-ischemic priapism, not very tender, not very painful, so what are the things in history that you can ask such patients?
Any penile trauma.
Any penile trauma like urological procedures, any blunt trauma like any sport injuries, or if he was cycling. So these are the things that you can ask. So what is recurrent priapism? Stuttering priapism. That is again and again the patient will be having, but this duration is not 4 hours. It will be less than 4 hours, but the frequency will be more. Normally ischemic priapisms are recurring, but sometimes, very rarely, non-ischemic priapism can also be recurring. That are in conditions where there are anatomical abnormalities, like if there is any congenital fistula or if there is any arteriovenous malformations, you can have it as a recurring non-ischemic priapism. So these are the things in history that you should ask. Examination you already told. These are the examination things. Okay, then next, management.
So coming to management, basically it is corpus cavernosal irrigation, aspiration, and if at all...
First thing to manage is pain. So what are the things that you can give for pain?
Either we can give a penile block or we can give procedure sedation.
Penile block, you can give either dorsal nerve block or there are ring blocks. So what is dorsal nerve block? If you block the dorsal nerve, will the entire penis be having that anesthesia effect? No, it won't, because dorsal nerve is a branch of pudendal nerve. So penis is basically supplied by the sacral nerves, S2, S3, S4. So pudendal nerve comes and it gives as a branch. There is a dorsal penile nerve and there is a perineal branch. So the dorsal nerve will supply the dorsal aspect of the penis. So the ventral aspect is not supplied by the dorsal nerve. So how do you give a dorsal nerve block? With what do you give? What is the anesthetic that you use? Lignocaine. Without adrenaline you inject. You insert it till you reach in the where do you give? Dorsal penile block is given in the midline. Right. Normally you don't inject in the midline. Why? Because there are arteries, dorsal, there are cavernosal arteries and all, and nerves and all coming. So you don't inject in the midline. But in dorsal nerve block, you go with the needle. First you have to infiltrate the skin. and then you have to go deeper, hit the pubic symphysis, go beneath the pubic symphysis, you will get the suspensory ligament. So from when you reach the suspensory ligament, go withdraw it 3 to 5 millimeter back, then go laterally to one side and inject the anesthetic, come back, go laterally to another side, inject the anesthetic. This is the dorsal nerve block where you block both the dorsal nerves. And there is another ring block where you can inject the anesthetic laterally in 2 o'clock, 9 o'clock position, 2 o'clock, 10 o'clock position, or 3 o'clock, 9 o'clock position. You can inject through in a circumference so that there will be anesthetic effect. So this is very painful. So it's a very painful procedure also. So that is why a block will be an ideal pain management. Okay, so after managing the pain, what is the next step?
The idea is to aspirate the blood from the corpus cavernous. So either 19 or 18 gauge butterfly needle should be used, and it should be kept just at the corpus cavernous. That is like not at the base.
Laterally, very small, 0.5 centimeter or something inside. Because if you penetrate deep, it will damage the structures. So don't go very deep. So you aspirate first. So if you aspirate and you don't get any blood, so then what is the next thing?
You have to irrigate with saline.
Irrigate with saline, because after 4 hours the blood will be clotted. So you have to instill saline, 5 ml, 10 cc syringe you have to take, instill saline so that you mobilize the blood clots, and then you re-aspirate. So that is one thing. You do the aspiration also nothing comes, then you instill saline, then also nothing comes. Then what is the next thing to do?
We can try with other side also with 2 butterfly needles, or else we can use phenylephrine.
So once you instill, this is an ischemic priapism. In this patient, what did you do?
We had given initially we had done with a 18 gauge needle, butterfly needle. Initially it was blood flow was there, and after
so what was the color of the blood?
Dark red.
Why is that dark red?
It's venous.
Venous flow, deoxygenated blood. So we did that.
Then after some time, like it was not coming. So initially tried with irrigation. That also was not working. So we had kept another needle on the same side, and then tried aspirating through both.
So what is the end point? How do you know that this is enough? You can stop the aspiration. What is the end point?
Stop when there is bright red.
Yeah, when there is bright red blood. That is the deoxygenated blood is over. The blood that is collected is removed, so that pressure is released. So did that red blood come? No, it didn't come.
It was
okay. And then what is, if this doesn't happen, then what is the next step?
Next step, we can inject phenylephrine. Phenylephrine.
What is phenylephrine?
Phenylephrine is
alpha agonist. Okay.
It will cause the
vasoconstriction.
And
what are the other drugs other than phenylephrine that can be given? Adrenaline, noradrenaline, ephedrine. But still we prefer phenylephrine. Why?
Less system.
Cardiovascular effects are less. But even though the cardiovascular effects are less, we have to put the patient on monitor and record his BP, because it can cause arrhythmias, hypertension, etc. Okay. How to give phenylephrine?
Phenylephrine ampule is coming like 10 mg per ml. So we have to take 1 ml, that is 10 mg in 9 ml NS. Diluted with 9 ml NS. So 10 ml, 10 mg. So it is 1 ml per mg. From that we have to take 1 ml and then again dilute it with 9 ml NS. So it is 1 mg in 10 ml, that is 0.1 mg per ml. From that we have to take 0.5 and then.
So the dose is 500 to 500 micrograms you give and you inject. So, and if it doesn't come, then if it doesn't resolve, the erection doesn't resolve with one injection, then what is the next step?
After 5 minutes.
Yeah, you can repeat. You can repeat this up to 1 milligram or up to 1 hour. Every 5 minutes you can instill phenylephrine with the patient connected to monitor. So if after 1 hour, if this doesn't resolve, then what is the next step?
surgical.
then only surgical method is beneficial. Surgically, what do? You can do shunts. You shunt the cavernosal vessel with the glands, penile vessels, glans penis vessels. You shunt the blood. That is the only way to remove. Okay. So, other than phenylephrine, there are other drugs to be used like adrenaline, epinephrine, noradrenaline, and ephedrine and all. Okay. So that is the management. So what if the patient, this is how we manage the patient. We didn't go for shunting. Okay. So what if the patient comes with non-ischemic priapism? What do?
Non-ischemic priapism is not a
emergency.
So
Okay.
we can go for Doppler and embolization can do.
Embolization can be done. So since this is an emergency, we don't go for investigations. But if you have to investigate a patient, this patient is a different case. He had given papaverine injection just for Doppler. But if a fresh patient comes with a priapism, what are the investigations that can be done for such a patient? Like what are the things? In this condition, it is not emergency because it is very clinical diagnosis. So you don't need an investigation to support your diagnosis. So, but if you get a thing to evaluate, what are the things that you can do? Maybe if the patient has any underlying hematological malignancies, you can do a CBC. You can check if the patient is having anemia, or you can do a Doppler and you can assess the flow. So if it is a high flow, or if the flow is normal or absent, or if the patient is having adequate flow, that you can check. So in certain patients, what happens if the priapism lasts longer? Is there any 4 hours you said? So what if the priapism lasts longer than 24 hours, 12 hours? What will you do? What is the problem why is this an emergency? What if we don't treat and the patient, this will last for longer than 24 hours? What happens? Ischemia induced irreversible changes like necrosis, fibroblasts will proliferate, fibrosis will happen. Patient will go into complete erectile dysfunction. So in such patients, you do put a penile prosthesis in such patients, and it is not necessary for some patients like old age who already have poor sexual functions and all. You can opt for a penile prosthesis earlier. So these are the ways to manage a non-ischemic priapism and an ischemic priapism. The only thing to note is in a non-ischemic priapism, since it is not an emergency, you just need to observe the patient, and if he is having pain, you manage the pain, and you can send him on an OPD basis, ask him to follow up with the urologist. But in case where the priapism non-ischemic priapism lasts for more than 3 days, 4 days, etc., the patient is still complaining of that, it can take up to 3 days. But if it lasts more than 4 weeks, then you have to do a Doppler investigations and see if there are any anatomical variations. In such cases, you will need to do surgical management.